I think that the Safe Heart Initiative is an incredibly important thing. We know from the previous EU plan on oncology how much benefit this has brought to patients, how important it is to have dedicated resources and a strategic plan to tackle broad areas of human disease.
Hello and welcome to the very first episode of Cardiomyopathies Matter. In this series, we'll be looking at cardiomyopathies, what they are, why they are so often overlooked, and why they matter for patients, for families, clinicians, and policymakers alike. To help us begin that conversation, we're very pleased to be joined by Professor Iacopo Olivotto, a cardiologist and one of Europe's leading voices in the field of cardiomyopathies. Professor Olivotto leads the cardiology unit at Meyer University Children's Hospital and the cardiomyopathy service at Careggi University Hospital. He is also professor of cardiovascular medicine at the University of Florence in Italy. Cardiovascular diseases remain the leading cause of death worldwide. So, in this opening episode, we take a step back and start with the basics. What cardiomyopathies are, why they are so often missed, and why they deserve a stronger place in the EU Safe Hearts Plan and in broader EU cardiovascular policy discussions. Cardiomyopathies are sometimes described as less visible heart diseases. They can be hard to recognize, and all too often people receive a diagnosis late or do not receive one at all. That delay can have a real impact, not only on patients themselves, but also on their families and on society. In our conversation, Professor Olivotto helps us unpack how cardiomyopathies differ from better-known heart diseases, why their psychological impact should not be overlooked, and how family history, genetic testing, and advanced diagnostics such as cardiac MRI can support earlier and more accurate diagnosis. So let's start here. What makes cardiomyopathies different from other heart diseases?
Cardiomyopathy is a term that is relatively recent, and it's different from cardiopathy. So cardiopathy, cardiac disease in general, this is cardiomyopathy, which means disease of the heart muscle. Because if you think about it, a lot of the cardiac patients have diseases of the coronary arteries, of the valves, have high blood pressure. And so the heart muscle is affected only at the second stage. It's like a secondary involvement. Some patients have a primary disease of the heart muscle. This is why it's cardiomyopathy, which means it's the actual heart muscle that is sick, that is diseased from the beginning. So it's not secondary. And why does this occur? This can occur because there is a genetic defect in the heart muscle. And this can be accompanied by a genetic defect also in the muscles of the legs or the arms, like, for example, you have in muscular dystrophy. Or it can be isolated in the heart, because only the heart muscle is affected. And the most common forms are called hypertrophic cardiomyopathy, where the heart thickens, or dilated cardiomyopathy, where the heart dilates and is not functioning very well. And we have other forms called arrhythmogenic, restrictive, that are a bit more complicated. So this is really why it can happen. There are also other causes. It could be inflammatory. For example, there are forms that are related to immune problems, or it can be mediated by viral infection. They can be caused by drugs. For example, some cancer drugs can cause dilated cardiomyopathy. We know that for sure. And so infectious disease and immune-mediated causes. So these are the most common. The main problem is that other conditions like myocardial infarction, for example, are very common conditions. So one disease affects millions of people in the world. Cardiomyopathy is a family of conditions which are individually uncommon or even rare. So many different conditions are part of this big family. So every single condition is uncommon per se. But if you put all these patients together, they form quite a big community. There are millions of people, again, in the European community that have this some form of cardiomyopathy, but it's very heterogeneous. And so every condition per se is harder to diagnose, and it's uncommon and so not familiar to the regulators and to the general public. If I talk to you about myocardial infarction, everybody knows what it is. If I talk to you about hypertrophic cardiomyopathy, many people will not know what it is, except when, for example, somebody important like a sportsman dies on the field, or when there is some important actor that's a testimonial for the disease. So this is the main problem. And also the fact that the patients are usually young, can be very young, can be children, and that they may have no obvious sign of disease, but they may have symptoms such as shortness of breath, chest pain, sometimes subtle, sometimes they don't even realize because they have been limited all their life, so they're not so aware of their symptoms, but they're still limited, and they may be impaired in their sports activity, in their profession, and they may also have incurred complications, including, for example, arrhythmias, which may be dangerous for their lives. So it's important that they are identified in a timely manner, because you may prevent these complications. And now some of these cardiomyopathies have specific treatments that can change the long-term outcomes. Symptoms are non-specific, so you can't really make a diagnosis based on the symptom or the condition of the patient when you see the patient. However, very often there is a family history of some sort. That is also sometimes, or very often, unrecognized. A family where several individuals have died prematurely or have had cardiac surgery or have died suddenly is a family that is very suspicious for a genetic condition and should be investigated. In fact, they should have family screenings for that and genetic testing when that is appropriate. So the problem is that in the general medical community, cardiomyopathies are not well understood, well known, and even in the cardiology community, even cardiologists are sometimes uncomfortable and may neglect, may not think about these conditions. There is now increased awareness. There are a number of campaigns because new treatments have come about, and new treatments bring out the necessity for a diagnosis. And there are campaigns, there are patient associations that are playing an increasing role, very important role. Patient awareness, patient empowerment is crucial here. A lot of people in the medical profession are not properly trained and are not capable of picking up the early signs. Some opportunities are missed. Symptoms can vary very much. So at the one end of the spectrum, we have patients that have a very funny heart, where the heart looks thick or large, and so the clear is disease, but they have no symptoms at all. And some of them may even perform sports at a very, very high level because the heart is still functioning very well, so it's in the early phase of disease. Then, of course, there is worsening of function over time, and they may end up having severe limitation. Sometimes the disease can be very severe from the beginning. We have children that require intensive treatment and sometimes transplant, or very aggressive heart failure treatment even at their very early age because the disease is so aggressive. So in fact, if you look at the case series for heart transplantation in young people, among the cardiomyopathies are the most common cause of transplant in young people, because they are the most common cause of heart failure in this population. As far as severe symptoms are concerned, these are mostly related to heart failure. So the inability of the heart to provide sufficient oxygen, sufficient blood supply to the body to meet the requirements. So patients may be severely short of breath, even walking in short distances or making one flight of stairs. Sometimes they're bedbound in the most severe instances because they're so severely affected. They may have severe chest pain when they exercise. They may have syncope. They even go into cardiac shock, sometimes quite abruptly, and requiring intensive care units. And on the other side of the spectrum, arrhythmias. You have some severe arrhythmias, sometimes leading to cardiac arrest, and sometimes leading to severe limiting symptoms, again, in terms of functional capacity. Many of our patients do feel like they are not completely understood by the general public and the community, because our patients look sometimes really healthy, but they are limited. There are definitely things they cannot do. Young mothers that cannot play with their children because they're short of breath. Young men who cannot just take walks or go hiking, or even more than that, sometimes they cannot do their jobs properly because they are unable to perform the duties on their job. Some of the jobs are prevented. They cannot be in the police force, on the army, or in the fire brigade, or even in factories where physically demanding jobs are required. This can be stable for many years. But then, of course, like in all chronic conditions, there may be things that tilt this balance. So they may be limited but stable. But then something may happen. For example, arrhythmias such as atrial fibrillation or ischemic episodes, or just progression of disease sometimes, spontaneous progression of disease, which alters this equilibrium and leads the patients to have hospitalizations, heart failure events, and sometimes they become in need of aggressive treatment, including transplant. The importance of making a timely diagnosis for cardiomyopathy patients has several aspects. The first one is that once the patients are correctly diagnosed, correctly assessed, and their risk is assessed, you may substantially limit complications. For example, you may prevent sudden death, you may prevent arrhythmias, you may prevent progression towards heart failure. Although, admittedly, we do not have any precision medicine for most of these conditions. So most of the conditions are not treated with specific treatment, but just with general cardiology treatment. Still, their risk and their outcomes seem to improve quite substantially once they are diagnosed, even though sometimes we're not completely able to stop the progression of disease. Then the other important aspect is the family aspect. So if you make a correct diagnosis in one individual, you may then screen the family and may identify early all the other family members which are affected and who are also potentially at risk. And the final aspect is psychological. A lot of these are patients who are, since they're young, are considered to be lazy, are considered to be wimpy. Why can I not do this? And why do I feel so bad? Why do I have this kind of limitation? It's not clear. Nobody's given me an answer. So if you provide them a biological justification for that and they understand the problem, they can, in some ways, overcome a lot of these difficulties because they realize what they had been putting up against. And we find that to be very, very important for their peace of mind and their well-being. The major obstacle for early diagnosis, I think, is as you say, general awareness, not only among general practitioners, but also among cardiologists and sports medicine doctors, for example. The other thing is that because the symptoms are very nonspecific, and sometimes the patient doesn't call for help, doesn't signal, doesn't highlight, doesn't blow the whistle. Patients just think it's normal, that they're just the way they are constitutionally made, which is being unable to do sports, for example, being able to climb stairs. They sort of think this is built into the system, so they don't ask for particular help. So on one hand, it's very important to have opportunities for screening, and this is something that really the community, including the regulators, should consider. So the possibility to have young people being screened at least once in their lives with an ECG, for example, which is a very good tool for early prevention. The ECG electrocardiogram is very cheap, is an easy test that can be done very quickly, and it's very informative. Sometimes it's extremely sensitive and can then lead to further testing, or to have at least a general cardiology check by somebody who has some awareness and some specific curriculum in identifying these diseases. Sports medicine is another good example. With sports medicine, you identify a lot of these conditions at the very early stage. But of course, not everyone does sports medicine screening. So to increase the opportunities for young to middle-aged patients, for example, or individuals to have this kind of screening is probably a good tool. Unfortunately, cardiomyopathies have a huge cost to society because these are cardiac diseases that occur mostly in young people who are professionally active. So it's not only a human cost, but also a societal cost. and they carry their burden for many, many, many years. And they require treatment and they require care. In some cases, early treatment can in fact modify the trajectory. So if you have systolic dysfunction, if you have heart failure, you can really treat patients. And with the drugs that are now available, you can definitely change not only their well-being and the symptoms, but also make them stable, give them stability over the years, avoid progression and prevent many of the complications. In other cases, we're not so lucky because we don't have specific drugs. So it is a very active field of research. We are very actively researching, and in the last 10 years, there has been an explosion of initiatives and investments looking at new drugs for these conditions. But again, because these are many different conditions, you need to find many different drugs, a lot of investments for groups of patients, sometimes a little small, so not very economically attractive from that point of view. So there are definitely orphan conditions that are still progressing despite early diagnosis. In that case, we can do relatively little to prevent progression and disability. So I think there's still a lot of work to do here. A substantial proportion, probably about 50% of patients with cardiomyopathies have a genetic condition, meaning that not only they have a family history, but they also have a gene that we can identify with genetic testing. And if we identify the gene, identify the mutation present in that family, we can then screen the rest of the family with genetic testing and identify the individuals that are at risk and those that are not at risk. So that is really why it's so important. Genetic testing is also important because it can identify a subset of patients that have specific treatments and have very effective treatments as opposed to others that still don't have any specific treatments. So that is really important. But of course, to decide which patient you want to test, you cannot test everyone. Genetic testing is now much cheaper than it was, but it's still expensive. So you have to prioritize. And family history is really essential. We should really have the habit as doctors, as nurses, to ask for family history in any patient that comes through the door for a number of conditions, but particularly cardiac conditions. One of the problems is that the cardiomyopathies have only been known in relatively recent years. So if you ask about grandpa or grandma or go back in time, those individuals never have had a diagnosis. So they all died from heart attack, which doesn't mean anything, of course. So it's not always easy but if you have a history of heart attacks in the family in young age, that's very suspicious because myocardial infarction, for example, don't usually occur in very young people and don't usually occur so repeatedly in the family. So whenever you have family where many things have occurred in the cardiac sort of domain, you should be suspicious. And then you should look specifically in that patient for other signs of specific electrocardiographic signs, specific evidence on echocardiogram, which are relatively easy tests, which can then definitely address your diagnosis and give you 90% of the information you need. For the remaining 10%, you still have to resort to complicated tests, including advanced imaging, such as cardiac magnetic resonance. It's an expensive, time-consuming test, but it's a very safe test, very advanced, that allows for incredibly precise definition of the heart shape and also the constitution of the heart muscle. You can see by MRI whether the heart is healthy or whether inside the heart you have areas of diseased myocardium, diseased heart muscle, and fibrosis, which is a scar. So these tools, together with genetic testing, allow us to have a really very comprehensive assessment of these patients and to really be very precise not only in our diagnosis, but also in our staging, meaning you can really understand at what stage of disease you are. Is it early stage? Is it advanced stage? Can we implement preventive measures, or should we go for late sort of therapies, advanced therapies, just to try to keep patients stable, but we've substantially missed the boat? This is really how we can understand. If somebody has a potentially genetic disease, you should test all the blood-related relatives, of course, not the acquired relatives, but of course, yes, if you have at least first and second degree relatives, it should be advised to have a cardiac screening by visit, ECG, and echocardiogram. And if you have a positive genetic test, then you can use that for further refinement. I think that the Safe Heart Initiative is an incredibly important thing. We know from the previous EU plan on oncology how much benefit this has brought to patients, how important it is to have dedicated resources and a strategic plan to tackle broad areas of human disease. In the specific area of cardiovascular disease, which is, of course, is now the main cause of death worldwide, there is still a lot to do. Of course, within this very broad initiative, everybody will be trying to prioritize different conditions. And of course, the conditions that are more common, such as those related to aging, to coronary disease, to hypertension, high blood pressure, will probably gain the most attention because there is so much to gain with relatively little effort, or still a lot of effort, but less intensive. In the field of cardiomyopathies, there is so much more to do because, again, the complexity of the different diseases that are part of this family, the fact that each disease is relatively uncommon, the fact that there are so many different problems underlying the same label, so it's not easy to have one intervention that will benefit all. You will have to provide tailored approaches. On the other hand, this is where future medicine is going. So future medicine, we know this from oncology, from the cancer field, future medicine is going to provide tailored approaches, tailored prevention, tailored treatment, and we can learn an important lesson from cardiomyopathies because it's sort of a pioneering field. A lot of the most advanced new therapies are being found in this specific field and then can benefit other patients with more common conditions. So I think it would be a great mistake not to include cardiomyopathies in the Safe Heart plans in a major way, not to include genetic testing, not to include policies for family screenings, and not to include funding for access, equal equity-based access in all European countries to advanced therapies, even though these are very expensive and, as of now, limited to a smaller subset of patients. There's definitely a return in investment because these are trail openers. These sort of new therapies open up not only therapies for those specific patients, but also new modes of treatment. For example, gene therapy is one example, but there are many other examples. If you open the way with these sort of very specific diseases, then there will be a return for many, many other categories of patients. Of course, there's a lot of interest, a lot of investment here that can be of benefit to the community. My key recommendation is when implementing the Safe Heart Initiative, keep an eye open and force the agenda to include genetic disease, to include a primary heart muscle disease, to include the millions of patients who have uncommon, individually uncommon, but globally quite common conditions that are characterized by genetic sort of transmission or genetic background and a familial environment. Please implement accurate guidelines for history, which should take into account the family context. So let's teach the physicians, the nurses to inquire about the family background. Let's multiply the networks of centers that are involved in care for these conditions. And let's make sure that these individuals are sufficiently represented in terms of funding and in campaigns and awareness in the next few years.
And that brings us to the end of this first episode of Cardiomyopathies Matter. A warm thank you to our guest, Professor Iacopo Olivotto, Professor of Cardiovascular Medicine at the University of Florence, Italy, for sharing his insights with us. Cardiomyopathies Matter is funded by Bristol Myers Squibb and Philips. Nothing in this podcast is intended or should be interpreted as promoting Bristol Myers Squibb, Philips, or any BMS or Philip product or agent. Thank you for listening, and we hope you'll join us again for the next episode.